Good afternoon, everybody, and welcome to our event, which is looking at social care in prisons on the island of Ireland. My name is Paula Devine, and I'm co-director of ARK. And ARK is a joint initiative between Queen's University in Belfast and Ulster University, which makes accessible social and political and general social science information on Northern Ireland to the widest possible audience. And one of our resources is the ARK Ageing Programme, which explores what it means to get older within Northern Ireland. And we're very pleased to say that this event today, looking at social care in prisons across Ireland, actually came under the instigation of Sarah Lawrence, who is one of the graduates of the ARK Ageing Programme. So we're very pleased that Sarah is very strongly involved in the event today. So the format of the event is we're going to have 3 speakers and 2 presentations. After the presentations, then we will have a discussion. So please put any questions or comments that you have in the chat, and we'll address those after the event, after the presentations. We're also recording the event, and we will make the video and the slides available on the ARK website within the next few days. Sarah has also produced a policy brief which focuses on her work in older and social care in prisons in Northern Ireland, and that will also be made available on the ARK website as well. So our first presentation is from Sarah Lawrence. As I said, Sarah is an independent researcher, but has recently graduated from Queen's University on her research, which looked at the health and well-being needs of older men in prison in Northern Ireland. So I will pass over to Sarah, who will tell you some more about her important research. Thank you, Sarah.
Okay, great. Thank you very much. Thank you, Paula, for that introduction. As she has mentioned, my research looked at ageing in prisons in Northern Ireland, and I had a particular focus or interest in the area of social care. But I also want to just, before we get started, thank Ali and Aidan as well for kind of broadening out this discussion. Social care is something that's very important for older prisoners, but it also is important for other groups in prison as well. So I'm really excited to hear from their presentations today and to really learn from them. So I'm going to start off by talking a wee bit about demographic change in prisons, and then I'm going to cover a little bit of the existing literature in this area, just to give you a bit of a background. I'm then going to move on and talk about the policy context, specifically in Northern Ireland. As Paula had mentioned, I have a policy brief that will be available later on today, and it goes into a lot of detail on that, but we'll talk a little bit about that during this presentation. And then I'm going to move on and share some of my key research findings from my PhD. We'll get started. So demographic change in prisons. In 2008, 11% of the adult male prison population in Northern Ireland was aged 50 years or over. And by 2015, this figure had increased to 16%. In England and Wales, between 2004 and 2014, the largest percentage increases across the prison estate was for those aged 60 and over, 125% increase, followed by prisoners who were aged 50 to 59. And more recently, in 2019, there was almost 14,000 prisoners aged 50 and over in English and Welsh prisons, representing 16% of the total prison population. In 2002, this age group constituted just 7% of the prison population. And I think it's important to share the those statistics from England and Wales, because sometimes, particularly in Northern Ireland, because we're a very small jurisdiction with a small population, you have to err some caution when it comes to percentages. But it really just goes to show that this is a real phenomenon that's happening in our prisons. So the main drivers of change In some ways, these increases reflect what's happening outside of prisons. We are living longer, we have longer life expectancy, which is a great thing. And that's one factor, but there's also unique factors that's impacting demographic change in our prisons, particularly changes within sentencing policy, which has led to people spending much longer time in prison. So these would be people who are coming in younger and they're aging in prison. In addition, there's been an increased pursuit in historical crime through DNA advancements and changes in attitudes towards sexual crime. And so we're seeing a wave of historic offences coming before courts and those people into prison. And that creates a very different population as well in prison of people who are coming into prison who are older and in prison for their first time. So some empirical research on ageing. The first thing that I think is really important to highlight and to keep in mind throughout this is that older prisoners are not a homogenous group. They represent, typically we use the age of 50 and above to suggest someone is an older prisoner. And we've had, people who are in their 80s, 90s, and I've even heard cases in England of someone who was over 100 who was in prison. So the needs of someone who is 50 years of age is going to be much different than someone who is 80, or older. So they're not a homogenous group. However, research has shown that older prisoners often experience worse health than community-dwelling older adults who are 10 to 15 years younger. Older prisoners have distinct needs that differ from their younger peers in prison, and the increase in older people inside prison requires some adaptation of services to meet the needs of a changing population. Healthcare providers also have challenges in that they inherit many of the unmet health needs upon someone entering prison. And given what we know about our social care systems, not just in Northern Ireland, but more broadly, it's very much likely that those healthcare providers are going to be tasked with meeting many unmet social care needs that were existent within the community also. Scholars have argued that addressing these needs is not just a human right entitlement and thus beneficial for the person, but it's also beneficial for wider society, because as we know, the majority of people do go back into the community at some point, and leaving those needs unmet simply exacerbates them and creates a bigger challenge. In addition, and particularly for older people, unmet needs may limit a person's ability to function independently within the community, and this creates a real difficulty for reintegration after prison. So I'm going to spend a few minutes going through the sort of policy context in Northern Ireland and some of the updates that have happened. In 2008, the transfer for healthcare provision in prisons from the Northern Ireland Prison Service to the NHS Trust officially began. There had been a similar change in England that had happened before this. And the idea behind this was that the National Health Service could provide a more professional service than a smaller kind of localised prison services that were providing healthcare. It was also felt that in enlisting an NHS trust to deliver health and social care services, that those services would be more akin to community standards. They also felt that in doing so, staff who were working within healthcare in prisons wouldn't feel professionally alienated, as much because they were part of a much larger organisation and they had those links to those practitioners working within the community. Although this process started in 2008, it wasn't formalised until 2012 for obvious reasons. It was a complex change, moving staff from one organisation to another and all of the agreements that were required. In 2009, there was a partnership agreement signed by the Director General of the Northern Ireland Prison Service and the Permanent Secretary of the Department of Health. And this, although this wasn't a legally binding document, it was a statement of intent of what they wanted to provide and what they were agreeing. And it very clearly stated that the aim was to provide health and social care services that were equivalent to what was being provided in the community in Northern Ireland. However, in 2011, the Prison Review Team reported that the funding that was transferred as part of this process only funding was granted for healthcare services and not social care services. And really that report kind of signaled that there were some challenges ahead in terms of social care in Northern Ireland prisons. In 2016, the Independent Monitoring Board reported that clarity was needed on responsibility for social care services within prisons in Northern Ireland. And again, in 2019, the Improving Health Within Criminal Justice strategy was published. And this again highlighted that there was perceived challenges in relation to social care. This strategy, it made a commitment to review new evidence and articulated that multiple organisations had a role to play in the delivery of social care in prisons, which makes sense. However, it didn't really stipulate who was responsible for what services. It didn't really get to that kind of granular level, particularly in relation to funding of certain services. So that leads us to 2021, where there still remains no formal policy framework for where specific services lie. And as I mentioned at the start, if you'd like to read kind of more on this slide, I have an article that will be published on the ARK website later on today. So I'm going to move on then and share some of my research findings. So my PhD was a mixed method study that I conducted across 2016. I started off with a well-manned survey, which looked at health needs, and I invited all men aged 50 and over in Maghaberry and Magilligan prison to take part, and around half of those men chose to do so. The survey was designed in such a way that we included different questions that were typically fielded within the Northern Ireland community, so Health Survey Northern Ireland, and that was really advantageous because we then could compare and contrast the needs of the older men in prison with those living in the community in Northern Ireland. So I'll just take you, I know this is a very busy slide, I'll take you on a quick whistle-top tour of some of those kind of key findings, which I think is quite timely because this week is also Men's Health Week, so just a little note to that. So 30% of the well-manned survey participants self-reported their general health as bad or very bad, which is almost twice that reported by those community dwelling sample. And again, that kind of reiterates previous research, which shows that older prisoners do indeed have worse health than those living within the community. There was also a disparity between the two prison locations, with participants in the Magilligan prison self-reporting their health more positively than those who were held in Maghaberry prison. And well-manned survey participants were more likely than community dwelling respondents to report their health as being somewhat or much worse than a year ago. However, there was a small proportion of prison participants who reported their health as better than a year ago, which again, I think is important. Even though it was a small group, I think it's still important to call out, as we'd said, this group of people are not a homogenous group. And there are those who are, when they come into prison, their health does improve because of the circumstances, of their life outside of prison. And I just think it's important to note. Out of the 83 well-manned survey participants, almost 70% reported that they had one or more health issue, with 1/3, and 1/3 had 3 or more health issues. The most commonly identified health issues, similar to those living within the community, were mental health, angina and heart conditions, diabetes, arthritis and back problems. 2 survey questions also explored participants' ability to carry out basic activities of daily living, such as walking, dressing and feeding oneself, and comparison of the Wellman survey data with those living in the community indicated a similar incidence of needs in respect of those activities. So I'm just going to move on then. I'm going to start to talk then about the qualitative research that I did as part of this study. So I interviewed 23 of the older men who had taken part in the Wellman survey. And they were based, as I said, between either HMP Maghaberry or HMP McGilligan. I've grouped some of the kind of key themes that came out of those interviews. I'm going to kind of elaborate a bit further on those. So the key challenges identified by the older men in prison. The first really was the immediate prison environment. Many of the older men, particularly those who were in prison for the first time, expressed feelings of shock, fear, alienation and inexperience. Unlike some of those who, have maybe been through the prison system and are kind of, unfortunately, very unfortunately, quite used to the environment. These were people in, their 60s and 70s who, although they were going through the judicial process, they were hoping that they weren't going to be sent to prison. And so there was a lot of shock, and that shock, really stuck with them for, those weeks and months that they first came in prison. They were fearful, they were finding themselves as older people, in this completely alien environment. If anybody's ever stepped foot on a committal landing, you know that it can be a noisy place. There's a lot of hustle, there's a lot of bustle going on, and that created, anxiety and fear for those older men. They felt vulnerable. Alienation was another, strong theme that came out. It was this feeling that they were older and the majority of people were younger, and that they found it difficult to relate to other people, and to, strike up sort of, friendships or, with other people. It's kind of alienation. And as I mentioned then, that kind of inexperience. Before I move on to the next challenge, this research was undertaken in 2016, and I still have ongoing work that I do within Northern Ireland prisons. So I think it's worthwhile as we go to maybe mention some of the things that have happened since this research, just so that others can learn as well from some of the innovations, improvements. Something that I was really delighted to see a couple of years ago when I went to Maghaberry prison, and I was in the reception area, was the peer mentor, or the peer mentor scheme that they have when people come into the reception. And although that had been existing for a while, there's other prisoners that meet people who are coming in and just kind of like a buddy system. One of the guys, he was an older person, and he had said, he specifically was there just to kind of keep an eye out for older men, because they had identified that, even if you have that kind of buddy system, an older man would appreciate maybe another older man to be that buddy. And so I just thought that was, something that was quite simple, to implement, but seemed to have an impact. The next challenge that the older men really identified was lack of purposeful activity. Gym and education, although these often appealed to younger men, they weren't really so much of an interest to the older men. The gym, gyms in prison sometimes are stereotyped as being these kind of hyper masculine environments, and the older men just didn't really resonate with them that was what they would want to do. In terms of education, many of the men that I met had very long and often successful careers. So the sort of basic courses and education that would be available for a younger population who maybe hadn't the same educational attainment just wasn't appealing for them. So this lack of purposeful activity, made the sentence longer in a way, because you don't have things to occupy you. It just kind of adds length, in how it's experienced. So some of the activities that I did see when I was there, I mean, and I'm sure, anybody, who's been working in prisons will know the horticulture programs are one that tends to really attract older men. They enjoy that. There was also, it was sort of an activity that happened sort of as a once-off, where they had some musicians come into McGilligan prison. And I was there when I was out doing my research when this was taking place, and the men were just amazed by it, because it was something different. It was something to talk about, and they were just amazed by it. So sometimes just those once-off initiatives can have sort of a big impact on people. Separation from family and community was another huge challenge, and again, different groups of prisoners experienced this differently. So for those who had come into prison early in life and had aged in prison, very often when they were coming up to being, released, temporary releases, or, going back into the community, they just felt completely alienated. The world had moved on, and that created a real challenge in terms of, looking forward to finding their place within society. The opposite then, for men who had come in quite late in life, was that they'd lived a whole life in the community. They had now been removed from that community or that family that they had lived with for decades, and that was quite a profound thing to have happened. And also challenges depending on the types of crimes that people were coming in for. That created a real challenge, and that they felt like because of the stigma attached to that they would never be able to go back to that community or perhaps family. Another challenge related to health concerns, obviously, the increased likelihood of having ill health and being in prison, and a real fear of dying in prison. And there's probably a whole nother event like this that we could have specifically on the area of palliative care, which perhaps we will. But yeah, that's another huge area. And then significant challenges accessing services and support for needs upon release. And I'll touch upon that probably a little bit more in the next slide, just because very often it was probation staff and staff working in resettlement that were tasked with trying to put those things in place, and they experienced some particular challenges. We'll just move forward. So again, along with the interviews that I did with the older men, I also did 15 semi-structured interviews with staff working in the key stakeholder organisations. So these were the South Eastern Health and Social Care Trust, the Northern Ireland Prison Service, Probation Board Northern Ireland, and also the Independent Monitoring Board. The key, as you can see from this picture, one of the key kind of themes that came out of that of those interviews was around clarity on specific roles and responsibilities relating to social care. Just was, concerns about, if people needed specialist equipment, who would cover the cost of that? How did we get assessments for people? And lots of kind of uncertainty. Also, the area of personal care was another example of that. At the time, particularly in one of the prisons, they felt that personal care wasn't something that those qualified nursing staff, were tasked with doing. But as nurses, they couldn't allow those needs to go unmet, and so they did it. But because that was kind of their ethos of care. But there was still question marks over, who should be providing that. There was also an absence of a care manager, which would be equivalent to community social care provision in Northern Ireland. In Northern Ireland, there would be a care manager who coordinates all different activities, and an absence of that person, left a lot of uncertainty. It was other staff who weren't necessarily working or trained in the areas of social work or social care, that were tasked with putting things together. A really, really big challenge that both probation and resettlement staff experienced was an unwillingness of social care trusts external to the prison, so not the South Eastern Health and Social Care Trust, but other trusts, to accept responsibility for social care provision when someone was released. So this really relates to jurisdiction. So if a person was released from McGilligan prison and or was going to be released from McGilligan prison and move into a different jurisdiction, probation staff had real challenges in trying to get all of the supports and services in place for them before that person left. The other healthcare trusts at times would have this reluctance where they would say that, you know, it's not their responsibility until that person comes to live there. But for probation staff, you know, they couldn't just be releasing someone without having all of those things in place already. And also, you know, a horrible experience for the person, you know, not knowing where you're going, what's going to be there. So that was a real challenge, and I believe that still, you know, there still is no formalized pathway in relation to that. The other concern, I suppose, was that, you know, the staff in the prisons, particularly in the McGilligan prison, you know, they were coordinating services on an ad hoc arrangement. You know, key staff saw what the issues were, worked together and put mechanisms in place in the absence of policy and formalized pathways. They put things in place, but they did have concerns that as an aging population increase, or as the population ages and the demand increases, it could lead to those ad hoc arrangements becoming overwhelmed. And also, as I've mentioned, you know, when you have, you know, great staff, key staff getting together and putting the solutions in place, you know, those are great staff. They might not stay in that role forever. They may at some point move on to a different role. And when this happened, it really exposed the fragility of these ad hoc arrangements. So that is the end of my presentation. Thank you very much for listening, and I am going to hand over to Aidan.
I'll just do a quick pass over here. Sarah, thank you very much for that really fascinating insight into the research that you did for your PhD, and which I think will be ongoing as well, and some very important questions that you've highlighted. Our other presentation today then is we're moving from older men in prison in Northern Ireland to female prisoners in the Republic of Ireland. And we have two speakers. The first of whom is Aidan Cooney, who is a mental health social worker in the HSE Community Health Services, as well as then Ali Duggan, who is a mental health social worker working for the HSE National Forensic Mental Health Service. And their presentation is called Making the Invisible Visible, which are social care considerations for female prisoners in Ireland through mental health law, policy and practice insights. So after Aidan and Ali's presentation, then we will have a discussion section. So please put any comments or questions that you have into the chat function. So pass over to Aidan now. Thank you.
Everybody hear me, yeah? So I'll start away. So I suppose when social worker Dr. Sinead O'Malley had informed me of the seminar being developed by Dr. Lawrence, it fitted in neatly with the work I've been doing in the National Forensics Mental Health Services and recent submissions I made to the expert panel on Mental Health Act reform. In both presentations, I was highlighting the absence of social care legislation and the need for codes of practice, social care needs and outcomes as per Mental Health Commission of Ireland's role and responsibilities for those who come into contact with the mental health and community and forensic services. During my time in the National Forensic Mental Health Services, I was the senior social work lead developing a social care needs outcome measurement tool, the Camberwell Assessment Need Forensics version, as part of a suite of assessment tools at case conference, but also in pre-admission, transfer from prison for treatment and discharge planning to the R&R team. In terms of social care outcomes, this work developed a safeguarding policies through social care needs in the forensic service. It defined the social care process in forensics mental health services. So when people were being assessed, we weren't just looking at the criminogenic, we're looking at the non-criminogenic needs during treatment and also at discharge. It also established clear social care outcome framework as per quality improvement in forensics mental health services. So once again, social care need was seen as equally important as, say, medication management or involvement with psychological therapies. It also allowed us to measure whether needs were being met, unmet, and looking at the patient's strengths in terms of recovery. What I drew from this quality improvement experience and from the submissions I made on Mental Health Act reform in Ireland was that there is a need for social care legislation, policy and service development. So hopefully over the next couple of minutes, I'll be able to outline the argument for it. So in terms of slide 2, can people hear me? Yeah, great. In terms of slide 2, women encounter considerable challenges on the pathways through criminal justice and/or forensics and community mental health services if they're diverted through this pathway. This presentation will focus on mental health law and policy that impacts on prisoners trying to access social care outcomes that are applicable to women. First section will look at the prevalence of social care issues among female prisoners and reflect on those prisoners who primarily need is mental health support. The second section will critically consider how mental health legislation framework considers social care needs of those in support. The third section will discuss the role of feminist knowledge in therapeutic jurisprudence regarding prisoners with mental health needs and social care outcomes. The next slide, slide number 3. So my colleague Alison Duggan will go into more detail on these issues as per Republic of Ireland stats in her day-to-day work. But in brief, we're looking at the IPRT said 4.2% of prisoners are females, and a majority of these women are detained on short-term sentences. The impact of even short-term imprisonment on women and their families is profound. The IPRT argued that this impacts on the economic and social costs to society at large arising from the imprisonment of women are very significant. In this slide here, I've looked at the person and environment framework, kind of a social care analysis of these factors of why women, men, or people with disability come into contact with the criminal justice system. As you'll see, this person and place attributes of criminality developed in America is a very good picture of kind of looking at the core personal issues, such as the 4 ones, such as addictions, mental health, and then it looks on the wider, on the outside, it looks at the more health and social care needs, or lack of them as somebody comes in to prison, and why they may come into contact with prisons. Issues such as the treatment system. A lot of women I've worked with who come into contact with the mental health system are experiencing domestic violence, and often they end up in the criminal justice system and their children come into care. There's homelessness. Women who come into the criminal justice system and mental health services often have homelessness or unemployment. So recent research has called for a special focus on how best to serve justice-involved women upon returning to the communities, the majority of whom will do so within days, weeks, or months of incarceration. The barriers faced by justice-involved women are compounded with the social stigma of having a criminal record, sexual abuse, higher rates of sexual transmitted diseases, and often minority status. Therefore, women's needs, health, and social care are often unmet and unknown by the criminal justice system, the mental health system. So Baldwin's research actually highlights very little research has included or focused on females' experiences on why they come into the criminal justice system, with studies focused entirely on male samples or including small number of women. And I would have seen that in the National Forensics Mental Health Services. We had all of our assessments were really designed around male populations in terms of for offending and mental health outcomes. So prison, the next slide, please. Prison, women and gender specific considerations, moving the debate from health to include social care needs. As outlined in the previous slide, returning to the community, justice-involved women will face significant barriers. And the different health and social care agencies vary widely. And as you can see in this table here, the biopsychosocial model kind of looked at the different, I suppose, complexities that women will face from a biological, from a psychological and social, And these are the main themes that over the last couple of weeks I was able to extract from the research. And each one of these will interplay with each other, but also will create barriers. But from a mental health social worker's point of view, who's worked within community, who's working in community, but also worked in forensics, it's very clear that each approach under the HSE services is individualized, with very little integration, and very much how do women leaving prison with mental health difficulties, or how do women leaving forensics mental health settings, how are they supported to reintegrate back in to communities that are local, that they came from. Often they're more isolated by going to, I suppose, places that we determine the professionals is best placed to manage their risk, and therefore creating that stigma. So a lot of barriers, women who come into contact with both forensics mental health services, but also within the prisons, where I diverted back through the local mental health services. There's no, in short, there's no joint up working, and there's no integrated approaches. Slide number 4, please. So for the purpose of discussion today, I will focus on the mental health needs and social care outcomes of women in prison. So mental health is very high prevalence within the prison population through mental illness, disability, self-harm, experiences trauma, sexual violence, domestic violence, and early adverse childhood experiences. The IPRT interview in 2020 research believed that there was much more diversion for female prisons to psychiatric units than for male prisons. This is a massive impact for a community mental health social workers when somebody's diverted to what we call a approved centre. Well, what is the plan for them? Because often within those approved centres, it's about get the medication into them, stabilise them, and then put them into homeless services. And we've made these women more vulnerable by not giving them any interventions. And what shocked me for my time 9 years working within these settings is that there is no domestic violence interventions. There is no code of practice from the Mental Health Commission on social care outcomes, but there is a very good code of practice on ECT. So we can see they're going from very much male paternalistic criminal settings into male paternalistic psychiatric settings. And all the time, social care needs are seen as somewhere different. And as I'll discuss later on, in the Republic of Ireland, we should have a very good pathway because it's all provided by the HSE, whereas in Northern Ireland and in the other parts of the UK, it's very much local authorities and the health services trying to integrate. In Ireland, it should be straightforward. So I'll really be looking at how these women who've come from the criminal justice system interact with the mental health services. So policies and social care. So I looked at the various different policies. The Irish Prison Services annual report talked about more gender specific goals for women, but yet doesn't mention social care. It talks about health, psychology, occupation and employment goals. Doesn't mention social care. Probation service and prison services 2014, 2016, no reference to social care and integration. It's all about the management of the person going back into the community and social issues. So the program for government in 2011, 2016 requires 2 services to work closely together to ensure a better coordination to create an integrated offender management program, and that relates back to the probation service and prison services. And once again, it's about an integrated offender management program, and within that we see an absence of social care because social care is not explicit. It is about social support, social needs. So once again, we're looking at reoffending and integration through medical, psychological, and nursing outcomes with very little reference to social care. And next slide, please. So this really was when I submitted to the Mental Health Reform Committee. I outlined where in Irish mental health legislation do we mention social care, and in short, we don't. It was mentioned by at the recent ACJRD conference that there is no social care legislation. So what we really have is somebody who's coming through the mental health pathway. Really, the Mental Health Act is there for the processing of somebody to be involuntarily detained, treated and discharged. In the criminal justice system, which is, once again, it is somebody who pleads not guilty by reason of insanity, and once again goes through the National Forensics Mental Health Service, but once again there is not a very clearly defined social care program for women and men who pass through that forensic service. Once again, I've highlighted the Mental Health Commission under the Mental Health Act is given the function role. Section 23 of that Act is to produce codes of practice for mental health services to follow. Once again, social care, there's never been a code of practice in social care, is very much an invisible part of those codes of practice. So the legislation that we may bring social care in is very clunky. So you've got the Equal Status Act between 2000 and 2018. And to be honest, as a mental health social worker, it is very difficult to navigate that because it's very individualistic and it's based on person bringing the HSE to the Ombudsman or to whatever agency they require. There is also the Health Act 2007, care and support of residents in designated centres for persons, children, and adults with disabilities. Once again, you do have a legal right to a care plan, but what's contained within that care plan is very much not there's no clarity to it, unlike colleagues in the UK who have very clear psychosocial or social circumstances reports. So people with mental health, so citizens with mental health needs who pass through approved centres, their social care needs don't need to be teased out, nor do they need to be addressed before a discharge. So our mental health and policy and social care, once again, sharing the vision, talks about integrated care plans, does talk about social care, but doesn't really tease out what that social care will mean. It was quite interesting to see Professor Kennedy's model of care, that he produced a very good argument on the issue of transdisciplinary case management. And he made a very good argument that, you know, there's no point all of us doing the one thing. We should be ensuring that each one of the professions is doing either the health, the psychology, or the social care needs of the persons that do pass through forensic services and mental health services. And for women in prisons to access these services, that's really important as well. It shouldn't be just the psychiatrist doing all of this work. It should be, you know, there should be social workers in prisons where they're offering mental health and social care. So when we think about in the table that I've just outlined in the presentation, the mental health legislation, what I've just tried to do is highlight under each of the Mental Health Act legislations, the roles, responsibilities, and the social care legislation that intersects with the mental health legislations in Northern Ireland, Scotland, and the UK, or England and Wales. So as you can see, it's very clear in terms of social worker roles are clearly defined. Social worker psychosocial reports or social circumstances reports are clearly required within tribunals or review boards. And when it comes to supporting the community, there is a responsibility in local authorities, either through clinical care, clinical commissioning, or through the provision of services for very specific type of clients, disabilities and mental health. In Ireland, once again, as I've said, the HSE is one agency that when you look at our social inclusion or social care division, there is very little reference to prisoners, people coming through the mental health. It's very much focused on disability or over 65s. So if you go on to the next slide. So on my third and final section, where do we go from here? Well, I've long argued that feminist ethics of care and reform of our mental health legislation that would make social care more visible would be quite beneficial to all women, and very much would underpin the gender-specific argument. Feminist criminologists have written extensively on the impact of masculinity on women and crime. This focus has been on how masculine discourses legitimize violent crimes against women and children. Feminist scholarship has problematized women's health and reproductive rights in the past. And once again, those rights should extend now onto social care needs. What is it that women need beyond the medical and psychological and nursing needs when they pass through our criminal justice and mental health services? There's a large body of research, the evidence that the support and rehabilitation and supervision of programs for offenders to reduce recidivism has really been conducted through samples of men. Limited attention has been paid to the interventions, principles and practices that apply to women. Australian studies that looked at these kind of supports for women favoured services that were delivered by workers who were reliable, holistic, collaborative, and others stood the women's perspective and the focus on strengths, and they focused on their strengths. And Dominelli's exploration of women's experience of probation services highlighted that often when it came to social care needs, the probation was quite limited in what it could offer, but would end up diverting or referring women onto other services. So that lack of joint up working. So the therapeutic jurisprudence focus on feminism and social care in prison. Therapeutic jurisprudence opens up a critical space for interdisciplinary analysis of how the law and its administration impacts on the health and well-being of those influenced by it. An ethical care would move the focus away from risk assessments and management that underpins the coordination of integrated offender management programs. The IPRT's 2021 report acknowledged when it came to social care and women in prisons effectively the only place where some of the most marginalized women with complex needs were getting wraparound service, supports and shelter. And that's not good enough when you think about them people moving into community, how that is replicated. So next slide, please. So I took a go at this. I don't know if it's very good or, but once again, it looked at Joan Toronto's ethic of care for prison women and social care. So an ethic of care is an approach to personal, social, moral, and political life that starts from the reality that all human beings need and receive care and give care to others. The care relationship among humans are part of what make us human beings. We're always interdependent beings. So Joan Toronto's 4 elements of care was attentiveness, responsibility, competence, and responsiveness. So what I attempted here was look at philosophies of social care and looked at how Joan Toronto's work could tease this out. So sustainable development goals, you've got the principle of equivalence. I'm sure Alison will highlight this, that somebody that's in prison in Dublin from Kerry will not get a service within Dublin. In the UK, under the Care Act, they're very much wherever the prisoner is based or where they're going to, they should get the right level of care. There is promote the rule of law at national and international levels. And once again, you could bring in, if we had social care legislation, we could be promoting it there. Competence, measure the proportion of people on remand, and then responsibility, identify vulnerable groups. In terms of human rights, you've got structural barriers, equality, and legal literacy. So, and citizenship through social inclusion. Relationship-based, we look at the relationship, collaboration, respect, and shared decision-making. Strengths-based, helping person-centered, person's ability to learn and community. Safeguarding adults and gender-specific interventions. We have trauma-informed care, disability and ethnic and cultural issues. So once again, it is highlighting how Joan Toronto's work can get us to reimagine not what just the law should be, but how our codes of practice should also focus in terms of looking at social care and women. And once again, it's probably a clunky table, but it's a start of something in terms of making the argument. So my summary and conclusions, when considering the theme of this seminar, social care and prisons for women, the theme of invisibility is central to the gender-specific interventions and services for women involved in the criminal justice system. As the IPRT has highlighted, women's social care needs are being met in prisons, whether that be for mental health, substance abuse, or even trauma. This seminar raised the issue of invisibility of social care. This seminar, I suppose, has raised the invisibility of social care and opens the space for therapeutic jurisprudence discussion of reform when it comes to legislation that frames prisons, probation, and mental health when it comes to rehabilitation and integration outcomes. And as I say, hopefully this seminar will reflect on this is a start, and that's my presentation.
Thanks, Aidan. My name is Ali Duggan and I'm a mental health social worker working with the Prison Mental Health in Reach team in the Women's Prison in Dublin. This is the larger of the 2 female prisons in Ireland, having a capacity of 140 plus. Aidan very comprehensively set the scene with the legislative and policy context of social care for women prisoners in Ireland, and I will now reflect on my professional practice observations with this demographic. Next slide, please. So it's important to acknowledge that there is a strong interagency approach by dedicated staff to the health and social care needs of women in Irish prisons. For example, between primary health care, prison mental health in reach, addiction counselling, probation service, psychology, psychotherapy, the National Traveller Service, and more. However, there are also many structural barriers caused by legislative and policy gaps, and these service users and their health and social care professionals face during committal and for release. In practice, these barriers further marginalise and disadvantage already marginalised and disadvantaged groups: women, survivors of trauma, those with mental health issues, the homeless, mothers, those with an intellectual disability, and ethnic minorities. Next slide, please. So first, I'll discuss women's committal to custody. As Aidan highlighted earlier on average, women make up around 4.3% of the prison population in Ireland, with a large number of committals concerning non-violent offences such as shoplifting and handling stolen goods, and the majority are detained on short-term sentences. The numbers of female prisoners continues to rise in Ireland, and overcrowding is a challenge. Women are more likely than men to be remanded to prison for offences that would not lead to a custodial sentence. High rates of remand into custody of women are linked to chaotic lifestyles, inability to adhere to bail conditions with supports in the community, and inability to pay the bail bond, rather than potential risk of committing serious offences if released on bail. Women commit fewer violent offences than men, and women's violence tends to be more reactive and relational. There are no open prisons for women or other gender-responsive community-based alternatives in Ireland. Gender-specific bail services, tailored supports, and community-based interventions could be used to address the current over-reliance of remand into custody for women accused of non-violent crimes. Women could be kept out of prison through addressing issues that contribute to offending behaviour like addiction, mental health, housing and homelessness. Losses of women's imprisonment to the individual, family and society include informal caregiving, childcare, housing, employment and more. In a study of female prisoners in Ireland, it was documented that they are a very vulnerable population with special needs, and compared to their male counterparts are more likely to be from poor social backgrounds, have an average of 2 to 3 children, are less likely to be in a relationship, and tend to have had prior psychiatric treatment. Therefore, a special provision must be made for the gender-specific health and social care requirements of female prisoners in Ireland. Next slide, please. So now I'll discuss the group of survivors of trauma. Trauma is extremely prevalent in the lives of women, and women are at a greater risk for negative consequences following traumatic events. For example, women are twice as likely to develop post-traumatic stress disorder. Adverse childhood experiences are commonplace in the women's prison population. In general services, the majority of people will present having experienced at least one form of childhood adversity. In services targeted at vulnerable populations like prisons, almost all service users are likely to be survivors of adverse childhood experiences, and in most cases, multiple forms of this. There's a complex connection between past experiences and impact on current well-being and behaviours. Adverse childhood experiences are predictors of homelessness and involvement with the criminal justice system. Thus, intergenerational trauma and incarceration are observed in practice. Incarceration and associated losses is a traumatising experience in itself. Prison health and social care processes, policies, practices and buildings can all trigger and re-traumatize survivors of trauma, push them outside their windows of tolerance and threaten their successful engagement with service providers. Trauma-informed approaches seek to support service users with the history of trauma to engage meaningfully in health, social care and community services, to remain engaged, to develop resiliency, to reconnect and explore supportive relationships. It is essential that a trauma-informed approach is adopted by prison services in Ireland, leading to better service user experiences and positive health and social care outcomes. Next slide, please, Sarah. Thank you. Now I will discuss mental health. Prevalence of mental health issues and self-harm and suicide attempts are higher among women prisoners. In a study completed in 2005, 60% of sentenced female prisoners in Ireland had a lifetime history of mental illness. A year later, Dr. Brenda Wright and her colleagues assessed female prisoners in Ireland, including those on remand for mental illness. Their findings were significant psychiatric morbidity, psychosis of 7%, depression of 40%, substance misuse of 70%, and significant mental health needs in a very vulnerable population. The Committee for the Prevention of Torture in their 2020 report on Irish prisons described the treatment of mentally ill prisoners as one of the most pressing issues within Irish prisons. Prisons are not approved centres under the Mental Health Act 2001, therefore patients are never medicated against their will. Patients may lack insight into their treatment needs and remain acutely mentally unwell in custody until diversion or transfer to mental health inpatient care can be organised. There is limited bed capacity in the designated centre in Ireland, the Central Mental Hospital in Dublin, for prisoners requiring both mental health inpatient treatment with high security needs. Acutely disturbed patients with mental illness are often confined to isolation lockup cells. Solitary confinement has no therapeutic benefit and can be harmed if prolonged for more than the shortest of durations. Prison is an inappropriate environment for treating mental health issues and can exacerbate symptoms. Historically, Ireland closed psychiatric hospitals in favour of a community-based care model. There are chronically under-resourced community mental health services since. For those requiring diversion from custody to inpatient care, there is no clear pathway to local approved centres for people of no fixed abode due to the catchment area system in Ireland. This can result in mentally ill women languishing in prison. Furthermore, previous and alternative diagnosis by the local mental health service and local approved centre may lead to failure to admit and allow diversion from custody. For those not requiring diversion from custody to inpatient care, there is no clear pathway to community mental health services for people of no fixed abode or those released to probation service transitional housing, again due to the catchment area system in Ireland. This can result in women with ongoing mental health needs post-release being excluded from community mental health services. For those women with an address, there are delays in securing timely community mental health service outpatient department appointments for patients leaving custody due to stretched community services. Next slide, please. Now I'll discuss the issue of homelessness. The relationship between homelessness and crime is strong and multifaceted. Women in the criminal justice system are particularly at risk of homelessness. There is a national homeless epidemic in Ireland. A major concern for the Committee for the Prevention of Torture in their 2020 report was the rising numbers of mentally ill homeless people ending up in prison in Ireland, and it directed that prisons must not become a solution for managing mentally ill homeless persons. When a woman presents as mentally unwell at arrest, diversion to a local approved centre from arrest prior to a charge or court appearance is a function of the arresting Gardaí, the Garda General Practitioner and local consultant psychiatrist of the appropriate approved centre. This frequently leads to homeless people being charged with public order offences and committed to prison when disagreements over catchment area arise. It is not uncommon for mentally ill homeless women to have been sleeping rough prior to committal, having been significantly at risk of sexual victimisation. They may be excluded from homeless services or unable to effectively engage in the social housing application process due to their mental state. Once committed to custody, there is narrow referral acceptance criteria by prison resettlement services for housing and homeless placement advocacy, including non-provision of this service to women on remand. This is of great concern in light of the well-observed and documented extreme vulnerability of women on remand. Furthermore, there are women who purposely commit offences with the hopes of receiving a custodial sentence for respite from their day-to-day lives and accessing housing support in prison. However, there is inadequate housing supply and homeless services are overwhelmed, resulting in paucity of local authority homeless accommodation options, particularly supported accommodation. One-night only beds in low-threshold dorm room hostels are a commonplace offer from local authorities. Separate local authorities with distinct budgets and resources result in differential service provision depending on a woman's previous address prior to committal. There is reluctance from local authorities to guarantee placement for release to safeguard scarce resources. This results in the risky practice of last-minute coordination of placement. Lack of address leads to exclusion from many community services at release, for example, community mental health service, general practitioner under the medical card scheme, methadone treatment clinics, and more. This exclusion increases the risk of recidivism and recommittal. The next group that I'll discuss is mothers. Incarcerated mothers and their children face particular difficulties in maintaining their relationship and for mothers to perform a mothering role. There is potential damage caused to children through mother-child separation and disrupted attachments. Mother incarceration and mother separation are categorised as adverse childhood experiences, which increases the risk of generational trauma. In her 2018 research study on motherhood, mothering and the Irish prison system, Dr. Sinead O'Malley found that of the mothers interviewed, approximately 30% received visits from their child, 60% did not receive visits from their child, and 10% had no contact with their child. Over half of these mothers who did not receive visits from their child made that choice for some of the following reasons. Child was unaware of incarceration, prison was not a child-friendly environment, or the long journey for the child from home to prison. More than 75% of female prisoners are held in the women's prison in Dublin, which means that maintaining meaningful family contact is difficult for those from outside of Dublin. For those mothers in custody whose children are in state care and wish for child visits, the overburdened and under-resourced Child and Family Agency can pose challenges to their mothering role as an invisible and muted parent who is dependent on facilitation of continued contact by social workers. Dr. O'Malley and Dr. Carmel Devaney have called upon supportive social work practitioners to work alongside incarcerated mothers in an effort to retain and realise their parental rights and duties and maintain relationships with their children. Under the prison rules, a child can be admitted to the prison to remain with the mother up to 12 months of age. Conditions are that the mother's ability to care is not impaired. She must hold prime duty of everyday parental care and no child welfare issues are present. Alternative care arrangements are made otherwise. This means that the most vulnerable women are disadvantaged in their opportunity to mother their newborn in custody. Next slide, please. Now I'll discuss the group of intellectual disability. The only nationwide survey to quantify numbers of Irish prisoners with intellectual disability was in 1999, and it assessed that 28% had an IQ below 70. There is a lack of secure residential care placements in Ireland for adults with intellectual disabilities. A physical assault in residential care can result in committal and refusal by the service to re-accept the former resident. To coordinate complex releases from custody, specialised placements may be sought in the UK under Irish Ward of Court legislation, which is a lengthy process in practice. In the interim, the woman may be confined to an isolation lockup cell to minimise risk of physical harm. The Irish prison system currently does not have the resources or facilities to provide for the specialised needs of prisoners with intellectual disabilities. There is no intellectual disability multidisciplinary in-reach service in situ. 21 years ago, researcher Michael Murphy and colleagues recommended development of a diversion system from incarceration for those with an intellectual disability, similar to prisoners suffering from mental illness. Such a process remains non-existent in Ireland. Next slide, please, Sarah. Thank you. And finally, I will now discuss the group of ethnic minorities. Members of the travelling community are significantly overrepresented in Irish women prisoners proportional to the general population. Relative risk of imprisonment is higher for traveller women than it is for traveller men. Although travellers only account for 0.6% of the overall population in Ireland, it is estimated that they account for 22% of female prison population and 15% of the male prison population. The Irish Penal Reform Trust recommended development of a strategy for travellers in the Irish criminal justice system and provision of a targeted reintegration support. A prison is by definition not a suitable place to detain someone who is neither suspected nor convicted of a criminal offence. However, Irish prisons continue to be used to accommodate immigration detainees in certain circumstances. Asylum seekers have varying levels of access to health and social care services in the community, depending on which direct provision centre they are accommodated in. Omission of care, particularly for mental health needs, places asylum seekers at a greater risk of coming to the attention of the criminal justice system, and effective pre-release planning can be challenging when available community resources are lacking. Culturally sensitive and anti-discriminatory approaches are required to address the health and social care needs of women of ethnic minorities in Irish prisons. Furthermore, service users who are members of ethnic minority communities are more likely to be survivors of trauma. Therefore, trauma-informed approaches would complement practices of cultural sensitivity and anti-discrimination. Next slide, please. This brings us to ethical considerations in practice. There is a historical and cultural context of women's oppression, confinement and institutionalisation in Ireland since the 1920s. Extensive powers of patriarchy and Catholicism are apparent in societal structures. Approximately 10,000 women were confined to religious institutions between 1922 and 1996. The state was responsible for a quarter of these female referrals, as religious institutions were used by the Irish courts in lieu of the formal prison system. This context is important to consider when reflecting on current processes and practices with female prisoners in Ireland. In my own practice, I have developed a portfolio of wonderings. At present, are women sent to prison for their own good, to teach them a lesson, for their own safety, or to access services? Are there well-intentioned, unconscious, hidden biases in the Irish courts, incarcerating modern, vulnerable women for her own good? Are there gender, class, and ethnic biases amongst the judiciary demographic? Why are so many homeless women with major mental illness placed in custody? Is the system designed for this demographic? Are homeless people indirectly incarcerated for mental health treatment due to total inaccess or partially blocked access in their local community? Is prison being used as a last resort, or is prison being used as a dumping ground? Is this an abuse of the penal system, or is it an abuse of vulnerable adults? Is the system infringing on human rights whilst endorsing economic and social discrimination? And why is prison a revolving door? Is it fit for purpose? Next slide, please. And finally, there are also social justice considerations in practice. Angela Davis said, prisons do not disappear social problems, they disappear human beings. Homelessness, unemployment, drug addiction, mental illness, and illiteracy are only a few of the problems that disappear from public view when the human beings contending them are relegated to cages. In conclusion, it is essential that we make the invisible visible through our health and social care legislation, policy and practice for women prisoners in Ireland. Aidan and I appreciate your time and interest, and your questions and reflections are welcomed. Thank you.
Thank you very much to all our speakers, to Sarah, to Aidan and to Ali for such a fascinating and comprehensive exploration of some of the research, policy, practice, legislation and ethical issues related to social care in prisons across the island of Ireland, both in terms of male prisoners and also female prisoners. We would like have a discussion now, and any comments or questions are very welcome in the chat area. We have a couple of questions already, and the first of these is for you, Sarah. Be able to put your mic and video on. And if both Aidan and Alison would like to put on their video and mic at this point too, would be great. So Sarah, in relation to the challenges regarding the lack of purposeful activity that you mentioned, did you find that occupational therapists employed within the prison service were addressing any of this need?
In 2016, no, I don't remember any particular examples of that at that time. The interviews that I had, particularly with men in McGilligan, was that they had very limited contact with OT therapists or occupational therapists at that time, although I know that there have been quite a bit of work that's went into staffing profiles in Northern Ireland prisons, particularly over the last 2 years, and that there has been more roles, created, and I'm pretty sure that occupational therapy is one of those such roles.
Okay, thanks very much, Sarah. We have a couple of people asking in the chat if the recording of the video of today's event will be made available, and yes, the answer is yes. We'll put that up on the ARK website along with the slides, and we'll send out an email probably next week letting you know when that is available and give you the link to that. Also, somebody's asking about the various references used within the presentations as well, and we'll try and sort that out as well. We have a question here for you, Aidan, where does Aidan foresee a move towards social care provision in prisons within the Republic of Ireland with the current move towards the professionalisation of social care, for example, CORU?
No. The Health and Social Care Professionals Bill is really just about registration of professional titles. I'm strongly advocating for a Care Act, similar to the UK, that looks at the issue of needs and well-being legislation, that puts social care at the centre of safeguarding. And I think that's the sort of avenue we'll start seeing then for prisoners who want to access health and social care issues on release from prison. So I think the CORU is more professional registration, and will have no impact on the provision of social care legislation.
Okay, thanks very much for that. Say if anybody has any questions or comments, if they could put those in the chat function. Could I just ask one question for, say we're working across, our presentations are on the island of Ireland, but 2 different jurisdictions. If there, perhaps you don't know the answer, but is there anything, practice or legislation or policy that you've seen in the other jurisdiction that you think that would be a really important piece of work and that would work well in your own jurisdiction or within your own work? Any of our panelists want to think of anything that?
Yeah, Scotland. If I could move to Scotland in the morning and
Okay.
follow their legislation and their codes of practice, I would. It's extraordinary. Their codes of practice related to the Mental Health Act is just streets ahead in what I've read in terms of England and Wales and Northern Ireland. And it's just purely by the language. It's very explicit that people who are being treated, their needs are holistic, and the focus is about the least restrictive. And I believe they're updating it. But for me, as an Irish mental health social worker, if you know, we've got mental health, our codes of practice are so medical and so nursing that, you know, social care is not even considered. But I do have to say, Northern Ireland, Scotland, UK, and England and Wales are are streets ahead of us in terms of the codes of practice. You look at the entirety of the Mental Health Act, and then there's other jurisdictions that move into where the Care Act, they apply the Care Act, moves in then to prisons and making sure the social care need, if you're coming out through a mental health diversion program. So, but definitely Scotland at the moment is where my heart lies in this debate.
I think just to add to that as well, within Northern Ireland, I think the hope had been by having you know, one healthcare provider across all of our prisons, that would you know, solve some of the issues that you have with you know, different providers. But unfortunately, as I've mentioned, you know, the issues really relate to whenever someone is leaving the prison system then and moving to another area that health provider, the South Eastern Health and Social Care Trust, you know, they don't have jurisdiction for. In England and Wales, you know, they did reform. They had lots of issues with those jurisdictions because it was local councils, and there were so many local councils across England, and they had similar problems with jurisdiction. But more recent legislative moves have, you know, aimed to overcome that people have, you know, a right to access those services. And so, you know, hopefully they should have seen the improvements that we would like to in Northern Ireland.
Okay, thank you. Ali, have you any thoughts on this, or don't want to put you on the spot here?
I've learned to always just agree with Aidan, isn't that right?
All right, okay.
Jesus.
Good stuff. Okay, we have another question here. Aidan has mentioned that the situation in the Republic of Ireland should be better because of the integrated structure in Northern Ireland. While there is technically integration between health and social care, it is very siloed. So to what extent are problems in social care in prison a symptom of neglect in social care more generally? I mean, is it that it's specific to prisons, or do they reflect neglect of social care in the community as well?
I think that's a great question. We know that in Northern Ireland, social care has historically been very much underfunded. You know, even though we have this integrated system that should offer, you know, better outcomes for people, you know, that lack of funding is kind of a key problem. And, you know, it's similar to what I've presented, although there was, you know, a statement of intent that they wanted to provide equivalent health and social care within our prisons. You know, that wasn't delivered in terms of funding. And I think that really is a core component of the challenges that we're having both in prisons and in our wider community in Northern Ireland.
Okay, thank you, Sarah. Aidan or Ali, if any?
Yeah, I mean, the argument for social care, very much like yourselves up the north, we have only one provider, the HSE. So technically, it should be a straightforward, you know, process. Somebody's in prison, they have health and housing needs, you know, they go through our social inclusion and social care department in the HSE. But the problem, I think, from what I try to argue today, is our legislation is written in a way that it is about the legal processing. And I mean, Ali has touched on it brilliantly, the ethical issues. Republic of Ireland's Mental Health Act is only for the purposes of doctors. it is designed for how a doctor and a nurse will administrate a person through a very masculine process, stigmatizing them along the way. Social care is almost something that, like for 9 years working in mental health services, from an approved centre all the way up to the designated centre in forensics, not one domestic violence intervention for women, not one. Yet we have lots of child protection. So it's very much, our acts are the problem. They're administrative acts. They have no interest in the person, and they have no interest in the person's needs. And this is, I think, when myself and Alison and all other mental health social workers in forensics, we need to be advocating and highlighting that, yes, the policies are talking about integration, but the mental health acts are the biggest barrier to integration, because the doctors will turn around and go, simply not our job. But yet they work for the one provider that's supposed to provide holistic, integrated, step-down care. And it's quite interesting that when you looked at our sharing division, which is our new mental health policy, it doesn't even mention social work and talks about social care. So now you're going to have doctors and nurses and psychologists, and I'm not anti those professions, but supposed to be doing social care outcomes. So once again, I think we can have all the best legislation and the health and social care industry, infrastructure, but if our mental health law doesn't have something like the Care Act in the UK, or the Health and Social Care Act in the UK that talks about clinical commissioning of services, we're really going to have those problems that Alison has highlighted from a Republic of Ireland perspective are going to continue for the next 20 to 30 years.
I think another problem with the Mental Health Act is, although it uses the terminology of mental health, it's very much about mental illness. So, those people who do have mental health difficulties or personality disorders, addiction issues, even though they're all so connected in different ways, the legislation itself is very much about the treatment of people with mental illness. And there's other groupings that certainly can fall through the cracks massively, particularly when we don't have services in the Republic of Ireland specifically for people with personality disorders, and very limited services for people with addiction, particularly residential placement.
Okay, thank you. We have no other questions coming in at the moment. I think all your points were so well made and explained. Perhaps everybody's questions have been answered. We do comment that the point about legislation and appropriate codes of practice is a great point, and it is in fact relevant across both jurisdictions as well. If we've, here's another question. Do any of the panelists envisage a greater role for the probation service? And we've talked a lot about different professions and the roles between them. Anybody like to take that question, asking about the role for the probation service?
Certainly, I think there's a complex relationship there. Probation services aren't provider of health and social care. They're very much assessing people's risk in the community, but there's a tension there because a large proportion of them are, if not all of them, are social work qualified. So how do you do social work in a kind of carceral setting, which is probation, which is extended into a supervisory role in the community? I think it comes back, for me, it comes back to the lack of a social care legislation that would ensure better integration between the health and social care. So I know something I'm doing up in the Northeast is mental health social work, working with probation to look at the social determinants of health, people who are coming out of prison or people who come into contact with probation services, and how better to offer health and social care through a mental health lens. But I certainly think from all the research I've read, there's a massive tension for probation officers. So I would work in collaboration with my colleagues in probation to ensure that they feel they have a greater not understanding of disorders and treatments, but also what's the best integrated. Like I did training for probation officers, and I taught them about, I educated them on the role of the authorized officer which is like the approved mental health professional in England, and the approved social worker in Northern Ireland. So if somebody has a mental health problem, how do you get Mental Health Act crisis assessment? And that can be quite good, but I think there's a massive tension there.
Just quickly to add to that, certainly for in one of the prisons that I visited, probation staff were very much involved, and what Aidan's saying is absolutely right. They were kind of articulating that their role, you know, was about assessing risk, but in an absence of anyone else who could coordinate, you know, those social care services for people whenever they left prison, they found themselves, you know, taking on that role. And, you know, they felt that they needed more training in that area. You know, they were social workers, but they needed more training in the area specifically for older people, so that they were ensuring, you know, that they were able to put services in place for, you know, older people when they were returning to the community. So it's an interesting point.
Okay, thank you. So I think we'll maybe finish at that point. We've come to 4:30 as we had planned. I'd just like to thank all three of our speakers for a really fascinating insight and raising lots of questions, which I think will be a lot of discussion going forward. So thank you very much to Sarah and to Alison and to Aidan for joining us today, and of course to all our attendees. I'm afraid sorry we can't see you. Perhaps hopefully sometime in the future we'll be able to hold face-to-face events. So thank you very much. So look out for the video slides and the policy brief of the ARK website, and hopefully we'll see you again sometime soon. Okay, thank you very much. Goodbye.
Thank you. Bye.